Good morning, everyone. My name is Dr. Lonzetta Newman, and I am a professor in the Department of Clinical Cancer Prevention here at MD Anderson Cancer Center in Houston, Texas. This morning, we're going to talk a little bit about cancer screening, including updates in prevention, but all in light of the era of COVID-19 and what breast health disparities mean in this current society. I have no conflicts of interest to disclose. And our objectives for today include describing the benefits of cancer prevention and how this impacts one's risk, discuss the concepts of risk assessment tools, discuss the concepts of risk-based cancer screening, discuss early detection of breast cancer, and outline current guidelines and recommendations with regards to endocrine therapy. So to begin, the first question that we're going to poll the audience in is, what is the leading cause of cancer-related deaths in African American women? Is it breast cancer? Is it cervical cancer? Colorectal cancer? Endometrial or uterine cancer, or lung cancer? If I have done a great job at the end of this, we should all be able to get this right 100% in the end. So I think we'll give a few moments for the poll to take place, and you can answer the question now, and then we'll reveal the answer at the end. With that, according to the American Cancer Society, the estimated cancer cases and deaths are shown in regards to men and women. As you can see, there are predicted 893,000 new cases of cancer in men and 321 related deaths. Women, 912,000 new cases with deaths related in approximate number of 285,000. For African Americans, those numbers are indicated below. Though there will be 98,000 new cases of cancers diagnosed in men, 36,000 cancer-associated deaths will be are being forecasted for African American men, and for women, 36,000 deaths. So, in particular, what does this mean for women alone? So, of the new cases, most of them are breast cancer diagnoses, followed by lung, colorectal, uterine, thyroid, melanoma, and non-Hodgkin's lymphoma. All three account for 4%. The deaths are associated, though, 25% of lung and breast and bronchial tube cancers, breast cancer 15%, colorectal cancer 9%, pancreatic cancer 8%, and ovarian cancer 5%. So when we look at the number of deaths, excuse me, though breast cancers are more often diagnosed in women, in particular, the number of deaths that are associated with cancer-related deaths are more from lung cancer. That is the same for African American women as well. Though we are getting diagnosed with 18% of breast cancers, more than what is in the general population, however, we are still dying of lung and bronchial tube related cancers at a higher rate, though our rate is quoted as 20%, compared to general population of 25%. So the number one cancer death related to African American women is still lung cancer. That is particularly important because that is related to prevention. For men, similarly, prostate cancer is more often diagnosed. However, the number of cancer-related deaths are still highest in lung cancer. And of course, prostate cancer is higher in African American men compared to that of the general population. So According to the Centers of Disease Control and Prevention in 2018, this is how they chose to display cancer deaths rates from 2012 to 2016. And of course, you see Black men still had the highest rate of deaths associated with cancer compared to all of the other groups. Now, let us look at the newest slide, again from Centers of Disease Control. The highest group that is related to mortality associated with cancer is Black males, followed by white males, followed by Caucasian females, and African American females. So why is this important for us? This is important because of prevention. In most talks, we talk about prevention as a last measure. Today, I'm offering you prevention as the first measure. So this is important because there are many modifiable risk factors. Those include body mass index, where we look at a person's weight in relation to their height, and it has been shown that in regards to postmenopausal breast cancers, weight gain after the age of 18 and overweight and obesity are risk factors that are definitely modifiable. This is directly related to nutrition intake and decrease in physical activity. Increasingly, more research is showing that non-starchy vegetables have been shown to decrease cancer-related mortality. So we want to encourage our patients with alkaline diets consisting of more dark green leafy vegetables. We want to encourage patients to eat as nature intended and eat the food as nature provides. So other modifiable risk factors include combination hormonal replacement therapy, and we know we want to minimize the amount that is given to the patient and for the shortest duration of time. Alcohol is another modifiable risk factor because we know that more than one alcoholic beverage per day increases woman's risk of developing breast cancer. And certainly tobacco, as we discussed, though prostate and breast cancers are more often diagnosed in our communities, still cancer-related deaths are related to lung cancer. And the majority of those cancers, those patients have consumed tobacco-containing products at some point in their lives. So we want to encourage the things that we can do something about. So how do we, once we get patients' vital signs and all of that information, you can start to formulate how will you present this information to the patient such that it is received from a place of care and compassion as opposed to belittling and berating. So we do the next step in terms of risk assessment by calculating the Gale model, and the IBIS model, which is also known as the Tyrer-Cuzick model. So the Gale model, of course, is concerned with the patient's age, the age at which they began menstruation, the age of their first live birth, their race, family history of first-degree relatives only, and if the patient had previous breast biopsies, the number thereof, and did they include atypical hyperplasia. These factors are what we use in calculating and discussing with the patient their 5-year risk. If that is greater than or equal to 1.67%, as per the P1 trial, we discuss the use of tamoxifen as an endocrine prevention therapy. If their lifetime risk is greater than or equal to 20%, as deemed by their family history, we discuss additional screening modalities that they might benefit from in terms of early detection, since their risk is substantially higher than the general population. So, what are some of the discrepancies or other things that have been validated in terms of the Gale risk with regards to race. It has been validated in white and Caucasian women and has been shown to provide accurate estimates of breast cancer risk. The CARE model data was used for African American women, and it has also been validated for Asian and Pacific Islanders, as well as Latina women. So this is what that Gale risk calculation looks like once you have obtained that. Again, we counsel patients in regards to the 5-year risk, if that is greater than 1.67% in regards to endocrine therapy and their choices thereof, and lifetime risk, again, if it's greater than 20% in regards to additional screening modalities. So the Tyrer-Cuzick model, it differs from Gale risk in a number of ways. It uses extensive family history, so it goes beyond that of first-degree relatives. It also utilizes genetic factors, including men in the family, and it also incorporates some of those modifiable risk factors that we just talked about, including height, weight, hormone replacement therapy, and it differs from the Gale risk model that it also incorporates breast density. And this we will talk about later on as also a risk assessment tool that we have to better assess and have discussion with patients about additional modalities that might be of service to them. However, this model does not adjust for race. This is what that risk calculation looks like once you have plugged in all of the data. And again, counseling patients in regards to 10-year risk, as this distributes 10 as opposed to 5-year risk for the Gale risk model, and a lifetime risk of 27.9%, as in this case, 20% and higher, we counsel with regards to adjunct MRI for screening. And we've talked about the deficiencies of these current risk models. So how do we use this in terms of discussion with the patient and educating the patient to optimize patient outcomes, because we want to detect cancers at an earlier stage? This is to reduce disease site-specific mortality, to minimize both short and long-term effects of possible treatments and what could be associated with those. And it affords multidisciplinary care in a personalized plan of action that all team members can be engaged to personalize a plan for the patient such that they know what is to follow as well as what to expect in survivorship long term. So why do we screen for cancer? We want to decrease the burden of suffering from cancer. That includes mortality as well as the morbidities that could be associated with treatments and further compromise patient outcome. And we most importantly want to find cancer at an earlier stage when it is most treatable. So who do we screen? We screen asymptomatic patients who have at least a 10-year life expectancy. We also incorporate all those modifiable risk factors and the risk assessment tools so that we can clearly decipher who would benefit from screening. So with that, who is at increased risk for development of breast cancer? Those we know with genetic mutations as outlined BRCA1 and 2 and others. I have not included that in my talk today because I saw that we were having a genetic mutation presentation and focusing on syndromes associated with mutations. So if one is also at risk, if they have premalignant lesions, which include atypical lobular or ductal hyperplasia or lobular carcinoma in situ. If they've had previous cancers, they're also more susceptible to getting additional secondary cancers. if they have dense breasts, if they have been treated with radiation therapy, for instance, for non-Hodgkin's lymphoma, EBV, associated cancers, where they were being treated with radiation therapy involving the mantle, the chest wall region during breast development in particular. A family history of breast cancer, if they are African-American women, as we know that African-American women are less likely to get a diagnosis of breast cancer, but they're more likely to die of the disease if they do get it. Again, lifetime risk, as we just talked about, if someone is of Ashkenazi Jewish descent, and the host of modifiable lifestyle factors that we discussed. So with that, it is so important to obtain all of that information, including family history, because we know that most of the breast cancers are sporadic. However, 5 to 10% of those are associated with hereditary syndromes, and some, 15 to 20%, depends on the literature, are associated with familial cancers. This is particularly important when obtaining one's family history because we want to obtain who in the family developed cancer, are they alive or deceased, and at what age were they diagnosed. That helps us to establish would that patient benefit from genetic counseling and screening that panel testing might reveal some mutation for which the screening could be escalated and further modified in terms of personalizing their screening plans. Again, important in terms of the obstetric history as well, age at menarche, age at first parity, did they utilize hormonal replacement therapy, and for how long? So once we've gathered all of that information and you've assessed, is the patient premenopausal, postmenopausal, do they have a uterus or not, we can add additional modalities in terms of prevention as endocrine therapy. So all of this is based on the evidence that was first shown in the P1 trial, also known as BCPT, where tamoxifen was shown to reduce invasive breast cancers by 49%. And who benefited most from this group were those who had evidence of atypical hyperplasia with an 86% reduction. So this is an additional modality that we use in talking to patients while we're assessing their risk, screening, and providing additional tools that might be of benefit to them and long-term outcomes. So the following trial was the P2 trial, which was a STAR trial that looked at tamoxifen and raloxifene head-to-head, and the initial results revealed a 50% reduction in invasive breast cancers with raloxifene as well as the tamoxifen. Hence, this offered a second modality that we could utilize for patients. However, premenopausal breast cancer, to reduce the risk of in premenopausal women, tamoxifen is the only choice, but raloxifene can be utilized in, excuse me, I stated the wrong thing. Tamoxifen can be utilized in pre and postmenopausal women, raloxifene utilized in postmenopausal women. So then that led to a third trial that we have extrapolated data and counsel patients in regards to endocrine therapy, and that was the ATAC trial, where anastrozole was associated with less frequent complications and proved superior to tamoxifen in certain groups. And what was beneficial about this medicine was aromatase inhibitors were not associated with as much endometrial cancers, strokes, as well as venothromboembolic phenomenon. So this gave us a third medication that could be utilized in terms of prevention therapy. So always ask, past medical history, past surgical history. Did the patient have previous biopsies? And obtain those pathology reports for your own personal viewing. Then and only then can you make a better assessment in regards to the risk models, as well as counseling patients with regards to endocrine therapy. This allows us also to bring mindfulness to our practices, because the research has shown, in particular, Alson out of Oakland showed a study where Black men in particular were more susceptible to signing up for screening modalities, including invasive testing, when they were presented from a doctor that looked like them. So if we bring this mindfulness to our practice, we can show patients and deliver all what we have to offer in a more compassionate, caring manner, where we indicate that their lives matter to us, and what are the things that we can engage them in to help modify some of these risk factors. So remember, one size does not fit all. Risk-based cancer screening is recommended. It allows us to begin screening at earlier ages in groups that are of higher risk, allow for more frequent screenings, and add supplemental testing as needed based on that risk. So I know I wasn't asked to talk about colon cancer screening, but in light of the recent death of Mr. Bozeman, I thought, because African Americans are at increased risk for colon cancer, what are the current recommendations in regards to screening that we want to talk about? So I just wanted to present that slide, which led to the basis of colorectal cancer screening as 2018 guideline updates, that they have further increased when should we start screening, and that is age 45. In particular, that is based on data from 2015 that showed that African Americans were being diagnosed with colon cancers with larger polyps at diagnosis, from which the cancers arose, as well as younger ages. And that article is highlighted, Wallace from 2015. So we should take extra lengths when we have African American patients in regards to counseling and offering screening modalities that could be life-saving in some instances. So we will end with the question, what is the leading cause of cancer-related deaths in African American women? And as you might have guessed, it is still lung cancer. Though breast cancers are more frequently diagnosed, the deaths are still related to lung cancer. So with that, I will stop at this time and take any questions that you might have in regards to screening, prevention, and risk-based strategies. Thank you for your undivided attention.